Well, I want to welcome everybody to the Impact Education PayerTalkCE program, Managing Diabetic Retinopathy and Diabetic Macular Edema for Underserved Populations. I'll be your host today. I'm Dana McCormick. I am a Senior Director with Optum Insights, which is a consulting division of Optum and United Health Group. This PayerTalkCE program is jointly provided by Medical Education Resources and Impact Education and is designated for 0.5 contact hours of continuing education credit. Also, this activity is supported by an educational grant from Regeneron, and we'd like to thank them for their support. At the conclusion of the program, you will be able to complete an evaluation, which has to be submitted for you to receive credit. There'll be a part where you can click complete evaluation in the navigation on the side. And then once you've completed your evaluation, you'll need to click claim credit to either download your certificate or for pharmacists to submit your credit to CPE Monitor. So I am so excited and honored today to be joined by Dr. Jordan Graff. Dr. Graff is a board-certified ophthalmologist who specializes in diseases and surgery of the retina and vitreous. He is currently in private practice at Barnett Delaney Perkins Eye Center in Arizona. And I want to welcome you, Dr. Graff. And you want to just give a quick introduction, give a little bit about your background?
Well, yes, thank you, Dana. It's good to be here. Yeah, I'm in private practice in Arizona. I'm a retina specialist, been here for the last 15 years. In my practice, we cover locations across the state of Arizona. So we take care of underserved populations from the Navajo to the migrant populations, our Latinos, our Black populations in various parts of the state. We cover patients with all different types of insurances and care plans. I'm also a clinical educator and teach medical students, and I'm a clinical research scientist, so I'm involved in a lot of the cutting edge studies and trials for caring for our diabetic patients. So it's a joy to be able to be with you again here today, Dana.
Thanks, Dr. Graff. And I think based on your background, you're a perfect person to have this discussion with, because again, we really want to focus today's conversation around how we can better serve populations that have barriers and access to care issues, and specifically those underserved populations that have diabetic retinopathy or diabetic macular edema. So when you think about the patients that you serve in underserved areas and populations, what are some of the key characteristics and challenges that you see them face?
Well, this is a great question. We deal with this all around the country, and in my practice as well, there's limited access to some of the healthcare facilities or practitioners or specialists, and diabetes is more prevalent with related complications, and there are socioeconomic barriers, sometimes lack of insurance, an underinsured or uninsured population. And an understanding of the diabetic management can be tough as well, and as a result, there are higher comorbidities. Genetically, there are even different sub-strains, if you will, of diabetes that hit our Navajo and our Havasupai and our Hopi population, our Latino population, differently than they will in, per se, a Caucasian population. And then geographically, we have patients, when I travel out to remote outposts to provide care in Flagstaff or Show Low or Prescott when we're going out of the valley to our population out there, this is the big city, and they've driven sometimes hours on dirt roads from the reservation to come in for care. And transportation can be an issue, and language can be an issue. So they're not insignificant challenges that our underserved population faces.
No, and actually, if you think about just in general, as we think about just care for people overall, right? A lot of these things are barriers for all populations of people, no matter where they are or what their socioeconomic status is. So if you think about how it impacts everybody, and then how much more it would potentially impact, it does impact these underserved populations, I think it presents a significant issue for these patients specifically.
Absolutely, Dana, it does. And these are shared challenges that can be exaggerated by other factors that some of our underserved population faces.
So when you think about treating patients, how do some of the factors that we've just talked about relating to some of the barriers, how does it influence your treatment decisions when working with patients who have DR or DME?
Well, diabetic retinopathy and associated diabetic macular edema is the number one cause of preventable vision loss in the United States of America. It is one of my greatest battles. for we as retina specialists, as ophthalmologists, to save as much vision as we possibly can in all of our patients with the diabetic complications. And so trying to get the most rapid response and best response to medication, number one, and to save and preserve as much vision as possible is always goal number one. And goal number two is to make that as tolerable and convenient as we possibly can. So that means we want agents that will provide rapid response and durability, reducing the burden on the patient and their families. Those are kind of the two things that come to mind for me.
So as you think about the current treatment options that you have, what are some of the gaps and what would be some things you're looking forward to that could help improve care for these patients?
Well, we want to have quick response. There are sometimes inflammatory components and inflammatory cytokines and mediators that are affecting diabetic edema. And so there's sometimes multi-modes of action. So different mechanisms of action, more durable drugs, sustained delivery platforms. Some patients, anti-VEGF changed the environment dramatically just in this last decade and a half. Patients who used to have nothing but laser or steroids as an option, it's been a paradigm shift to have really effective anti-vascular endothelial growth factor medications. And now in this last decade, we've been trying to find the most effective options that last the longest, sometimes longer lasting molecules with new mechanisms or sustained delivery platforms, because the burden of coming in. There was a remarkable study that was actually published in the American Journal of Ophthalmology by Prenner in 2015 that showed that it was like 11.7 hours. It was some huge amount of burden when you think about the pre-appointment and the driving and the appointment and then waiting and getting testing and then the injections and then recovering from that. So trying to recognize that the least number of treatments and the most effective mechanism of treatment is a cost-effective consideration for the patient in getting the best outcomes and the lowest burden.
So thinking about how you approach therapies. So again, there's two different ways, right? You've got, comparisons of the drug's effectiveness, and then you've also got cost effectiveness. Could you talk a little bit about data that's out there that has looked at any head-to-head comparisons of the agents?
Yes, absolutely. So the DRCR.net Protocol T was a significant study that compared the efficacy of ranibizumab, bevacizumab, aflibercept in the treatment of diabetic macular edema. And all three drugs improve vision, but especially in the year one data, the aflibercept showed greater visual acuity improvement in patients with the most severe vision loss at baseline. And that's helpful to know. That's a very good drying agent. And actually just recently, just in this last few months, we now have access to aflibercept high definition, or the HD, if you will, that is an 8 milligram molecule now FDA approved for diabetic macular edema, which lasts longer and is more effective at reducing the edema. Likewise, we have now for this last, I guess, year and a half or two, we now have faricimab, which is a dual mechanism of action. Also, the data showing that that is rapid in drying and effective and lasting longer. And yes, you're right, Dana. These new medications, these new molecules are hundreds of millions of dollars in research and development, and to bring them to market is expensive, and they end up being expensive drugs. Thankfully, with the insurances, we oftentimes can get those covered, but it can be a bit of a fight trying to get those approved. And so we want to try and balance out what's the most effective, and sometimes we end up with things that are a little bit more costly in medications. There's a consideration, however, in that patients with these more effective medications don't need as many injections. So while the injection is more expensive, perhaps, the time duration and effective course of the pharmacokinetics of the drug for the patient allows them to get fewer treatments, which is, of course, our second of our two goals.
Sure. We talked a little bit earlier at the beginning about just access to care. What are some strategies that could help address this? Could you talk a little bit about the role of remote screening for DR and DME and the impact of the management of these conditions, like particularly for those that live in rural areas?
Absolutely. In fact, in this last decade, there have been some huge advances in some of the either AI programs or remote screening programs where cameras can be placed in remote areas. Non-dilating, non-mydriatic cameras can get good pictures of the fundus of diabetic patients closer to the reservation or the remote town or the remote location with very little operator skill set required. And then those can be either screened by AI programs or screened by live screeners who will then determine who needs to make that expensive and difficult trip to get in to be seen by a retina specialist. These telemedicine programs and remote monitoring technologies help increase access to specialized care, and they help reduce some of this sense that some of our patients feel if they come in and they don't need specialty treatment, they feel like they've quote unquote wasted their trip because we cried wolf and they didn't need to come in. So these kind of telemedicine programs help get greater access and greater outreach.
So I definitely think that since silver lining that came out of 2020 is, I think, as payers have been working with their employers, we have definitely seen a very large uptake of employers paying for telemedicine visits as a part of an employee's benefits. Can you talk a little bit about telemedicine specifically, and if you've had an opportunity to employ that?
I agree with you, Dana, that you look at the silver linings of what happened from 2020 and the whole COVID experience is that we actually can mobilize and utilize effectively some of these telemedicine programs that were available to us, but not really implemented. And necessity is the mother of invention. And now we're using these more broadly, and they're more accepted, and they're actually reimbursed so that practitioners can do this and make it a part of their practice. I think that that's helped us because earlier access to care and more rapidly getting rid of the bleeding and the fluid in the back of the eye in a diabetic patient results in better outcomes. And that's ultimately what we're trying to do of our goals. Goal number 2 is reduce the burden and increase access. But goal number 1 is always stop the bleeding and the fluid and save as much vision as possible. And this kind of allows us to do both. We get access, we contact them earlier, we get them in earlier for treatment with these telemedicine programs and fundus cameras placed around in remote areas. That's really helped to increase the reach of these physician extenders, if you will.
So thinking about the burden of treatment for patients, I think with the evolution of how physicians are using anti-VEGF therapies and considering, extend and treat types of options, can you talk a little bit about how extend and treat, or even products that are coming out that have extended opportunities for treatment options, provides patients opportunities, especially like thinking about patients who are in rural areas or have transportation vulnerabilities? Could you talk a little bit about that?
Yeah, absolutely. So it's the things that are coming down the pike are actually very exciting. Anti-VEGF therapy, monotherapy alone has been very effective, but stronger anti-VEGFs, like we mentioned, the 8 milligram dual mechanism of action, which is the faricimab molecule, both of which are now FDA approved for use in the diabetic population. Studies are ongoing right now and I'm a clinical research scientist in the trials for gene therapies, where you can teach cells in the body with suprachoroidal injections to make the aflibercept molecule in the eye. Teach the cells to do that. That's a remarkable thing. There are antibody fragments or fabs, these deutafabs, that have dual mechanism of action in smaller molecules. There are extended biologics and bioconjugate drugs that can be used. Extended release steroid implants, TKI implants, that's tyrosine kinase inhibitors that are being studied right now. It's really an exciting time in retina where we are now moving to that second question as we get more effective therapies that will allow us to have sustained delivery. There are studies ongoing right now with the FDA-approved port delivery system in the diabetic population, where you may be able to get 6 to 9 months duration of therapy. So it really is an exciting time to be able to have effective therapies that last longer for all of our patients, but especially our underserved patients, where access to care and travel to get in to see a specialist is burdensome.
So one of the things you mentioned earlier was, again, the expense that goes into developing these products, and then again, the expense that, they have when they do come out to the market and are made available for patients. So as payers have a responsibility for managing their clients' healthcare spend and help them design benefits that allow and provide for all of their patients, and then thinking about how these drugs are managed in patients that have in underserved populations. Can we talk a little bit about how healthcare providers and payers can collaborate to make sure that patients have access to the most effective treatments while also kind of managing costs and improving overall healthcare outcomes?
Well, that's a great question, Dana. And, you and I and this group participating in this won't have the perfect answer to this yet. But I think that the point is the very fact we're having this discussion means that all of us, practitioners and payers alike, are striving to find the answers. Because the economic aspects of the anti-VEGF treatments for diabetic retinopathy, diabetic macular edema is a significant factor when we determine accessibility and choice and opportunities. And so I think that it's important for us to remember our goals, and that helps us to come back to embracing, okay, how do we deal with the costs? If our goals are to get rid of the bleeding and the fluid and save and preserve as much vision as possible, restoring when we can. And number two is always in number two, and that's improved durability and reduced burden on the patient. Then we look at the different drugs and treatment options through that lens. And if we can confidently all look at each other and nod and say, yeah, these new treatment options do indeed more effectively get rid of the bleeding and the fluid and save vision, and or last longer to reduce the burden, then we do the calculus and say, yes, this costs more, but the patient's receiving a third of the number of treatments that they used to. In the case of aflibercept and faricimab, we have drugs that are now lasting 12 to 16 weeks in between therapy, whereas previously it was 4 to 8 weeks for treatment. Now we're looking at something that's 2 to 3 times longer, more effective, more durable. So if that medication costs 3 times more, and yet the patient doesn't have to drive in, we think that the only cost we're calculating is the cost of the medication. But in fact, 3 fewer visits, if we can accomplish what we're trying to with 33% of the visits, that's 33%, rather 66% less testing, less visits, less driving, less gas, less expense, less granddaughter taking off work to take grandma in for her diabetic treatment. That's 66% less of testing and imaging and doctor time and patient time. So it's not just the drug cost. There's a huge amount of other costs, like we talked earlier, in time and expense and healthcare dollars going into every visit. So if we can have drugs like aflibercept 8 milligrams and faricimab and other extended duration therapies, including extended duration steroids and sustained delivery devices, we're reducing overall the cost of healthcare.
I think just like we see, clinical inertia play out in the practice of physicians in any kind of disease state, I think we see kind of guidelines and prior authorization programs suffer from the same inertia impact. Yes. That, again, as we see significant improvements in care that's being delivered by new agents or even new approaches to care that can do the things that you just talked about, sometimes there is a delay in a plan's building those strategies into their approach to how they're managing, prior authorization. So hopefully over time, and again, the more conversations we're having just like this will help speed the time to getting those prior authorizations updated. And again, I know one of the goals of plans is to make sure they're representing what is being done in the, in practice, and what is in the best interest of patients. So I appreciate your insights and helping bring some of those new strategies and ways to approach improving care and decreasing the burden on patients forward to us. So I really appreciate your comments earlier, Dr. Graff, and thanks again for our conversation. And why don't we open it up right now for some questions from our audience? Dr. Graff, let me just ask your opinion. We've just been talking a little bit about the relative newness of the treat and extend as an option for effective care. And now we see agents that are coming that have longer durability. Is there any reason to believe that we will see decreased durability over time the longer these agents are in the market or these treat and extend approaches are used?
That's a great question, Dana. And I think that these, like a tachyphylaxis, for example, pain medicine, you reach a certain point and then all of a sudden you need more of it. And then you reach it longer and you need more of it. We're not finding that in the anti-VEGF space. The anti-VEGF, it's a very discrete molecule. Once it's blocked, very much like an antihistamine. You tend not to have to increase the antihistamine. We don't see so far. We've had faricimab on the market now for a couple of years, and I was a clinical research investigator for years before that. Eylea 8 milligrams now on this last year. We're not seeing that in the studies so far. So we don't think tachyphylaxis is going to be an issue. We think that this durability will prove true. And I know there are a couple of real-world studies ongoing. I'm part of a couple of those as well. And in the real world, we're finding extended durability of these new drugs.
No, that's great. So thinking about some of the new agents that are close to coming to market or maybe even a little bit further out, is there any one new mechanism of action or agent that you think will impact the way you practice more than others? What most excited about?
Well, I think that the probably three, an A, B, and C answer to that, Dana. A is we've already seen for 18 years now, 17 and a half years now, the massive effective anti-VEGF. So having a stronger anti-VEGF in the aflibercept 8 milligram is already well proven. We know that it's safe. We know it's effective. I think that faricimab, a dual mechanism of action that has the angiopoietin 2, seems to be showing the same kind of promise that way. And then the third would be kind of in C would be like tyrosine kinase inhibitors or some of the dissolvable biogels that are just on the cusp. Those aren't out in clinical practice yet, but those are probably the three most exciting drugs. And then, so that's A, B, and C of number 1. 2 and 3 would probably be things like sustained delivery devices and gene therapies. But we're really in space 1 for right now.
So out of all of those, will all of those have the ability to help improve patient adherence and acceptance to the treatment burden?
Yeah, I think it will. I think it's a more palatable thing. We oftentimes, as I mentioned earlier today in the presentation about the goal number 1 and goal number 2, obviously we tend to find ourselves focused on goal number 2, reduced burden, so that the patient is more compliant and that they and their family can tolerate it. And I acknowledge that that's rises to the surface of the patient, so long as we're not sacrificing goal number 1. And so far, what we see with the high-dose Eylea 8 milligram or the aflibercept and the faricimab, we don't seem to be sacrificing outcomes while we're making it more palatable for the patient to adhere to therapy. We've seen this already in the diabetic management space with some of the new drugs that help the patient be more compliant and get their A1C down without as big of a burden on the patient. I think we're seeing the same success in this field.
So you talked a little bit about, again, the importance of treating early, but let's go back before retinal disease has even started. And let's talk about prevention just a second. What are things that, again, this is a mostly managed care audience. What are some things that your organizations could be doing to support screenings of diabetic patients just upfront, initial, like all the time?
Thank you, Dana. And for this audience, this is critical for you and your payers and the organizations you represent to be thinking this through, because ultimately those who are doing the numbers at your organizations want to reduce how much has to go out per patient treatment. And earlier intervention and earlier treatment prevents the patient from getting to tractional detachment, proliferative disease, hemorrhage in the eye, going to the operating room, repeated surgeries. I have to deal with that all the time. And if the payers and in a managed care environment can support things like remote screening, telemedicine, masses of, and some of the payers are, COVID, as you pointed out earlier today, has helped. One of the benefits, that silver lining, we're doing some remote therapy, we're doing some remote access, we're doing some video conferencing. The more of that we do, the earlier we intervene, the less vision is lost, the better effect it has for the patient, And ultimately, the less the payer is putting out for treatment when you catch it earlier.
Thanks, Dr. Graff. I think we're kind of coming towards the end of the call today. And again, knowing that we've got managed care organizations on the WebEx today, what would be the one piece of advice or one thing that you want the folks that are on the call today to take away with them into practice?
Thank you, Dana, and thank you all for taking up your time for this. If you could just come away from here recognizing that not to be afraid of or intimidated by or concerned by potentially the costs and the newness of new therapies and new treatments, because ultimately it will give what we are all seeking for. Ultimately, it will reduce the costs, reduce the number of visits. We think it will reduce the damage to the patient. It will improve compliance, and patient wins. The doctor isn't overburdened with so many patients coming in every 4 weeks. And the payers ultimately, when they look at the big picture, they're not doing as many imaging, as many FAs, as many OCTs, as many visits, as many injections, even if perhaps the therapy is more expensive than what's currently out there. I think the big picture, we're coming on some real win-win-wins. And instead of a sometimes adversarial interaction, we have this partnership. And I like to see that.
No, well, Dr. Graff, I always enjoy talking with you about retinal disease. I think you bring so many great insights into how we can collaborate together and really focus on our end goal that we all share, which is improving patient care. So thank you so much for joining us today. I also want to thank Regeneron Pharmaceuticals for their support of this educational activity. And then the claim credits, please click on the complete evaluation. And then once the evaluation is complete and submitted, you'll be able to select the type of credit. You have to claim your credit in order to get the certificate or submit it to CPE Monitor. And if you please would take the time to provide feedback, and we really appreciate that to help improve the quality of these down the road. And again, this concludes today's webcast, and thank you so much for joining us. And I hope you have a good rest of your day and a great week. Thanks, everybody.